Good evening. I'm Mark Whiteley and I'm delighted to have been invited today to talk about venous leg ulcers. I'd like to thank the Venous Association of India and Raval Jindal and all of the board members for inviting me. I hope everybody's keeping safe during this horrible COVID crisis that we have at the moment and hope that we will all be meeting soon for proper meetings again. Most societies have problems with venous leg ulcers, and we know that of all the leg ulcers that cause problems, venous are in the predominance. We know that there are other ones, and it depends exactly which society and population you're looking at as to how many exactly are arterial or infective or any of the other causes. But in the vast majority of people with chronic leg ulcers or open sores of their legs, they are venous in nature. Traditional teaching used to be quite clear on the subject of varicose veins and leg ulcers, and although this has been disproven, as I'll show you, really since the 1980s onwards, many people, particularly nurses and primary care physicians, still seem to think this is the situation we have today. On the left here we see reflux in the great venous vein and varicose veins, and many people have thought that this is just cosmetic because it's superficial vein reflux. And erroneously they believe leg ulcers to be due to deep venous reflux or problems. So therefore, the traditional teaching is that in varicose vein surgery, if you just ablate or if you take away the reflux, you cure the varicose veins, and this is cosmetic only, and it doesn't really matter if you do it or not. Whereas leg ulcers need dressings and compression because you can't do anything to the superficial veins. And so therefore, compression and dressings has been the mainstay of treatment for leg ulcers for a very long time. However, some of the very early workers in the field knew this to be wrong, and right back in 1984, Dark from Bournemouth started showing that what they called in those days longs of venous, and we know now is greats of venous vein incompetence, and perforating confidence alone could be responsible for venous leg ulcers. And this was one of the first papers to point out that perhaps varicose veins aren't cosmetic, and perhaps they can go on to cause venous leg ulcers, and more importantly, venous leg ulcers, certainly some of them, might be curable. By the early 90s, and certainly this paper in 1993 showed that actually the majority of venous leg ulcers were due solely to superficial venous reflux alone with normal deep veins, absolutely showing that the superficial venous reflux alone is not just a cosmetic phenomena, but also implying that as we can treat the superficial veins, venous ulcers in the majority of cases can be cured permanently. However, one of the big problems with leg ulcers is they're not sexy, and a lot of young surgeons don't want to research them, and a lot of older surgeons don't want to treat them, and so it's left to nurses and other carers just to keep on binding them and treat it as a chronic disease. And it took to 2007 for a randomized trial called the ESHCAR trial to show that if you compare patients who have superficial venous surgery for leg ulcers versus those who have compression, those that had the surgery to the superficial venous reflux actually have fewer recurrences in the long term than those who are treated by compression alone. In 2013, my group from the Whiteley Clinic published our results for the last 12 years, and we showed that if you treat the superficial venous reflux, that's both the perforators and the truncal veins, using endovenous surgery, we found that over 12 years we had an 85% healing of venous leg ulcers, and 52% of those patients didn't even need any long-term stocking or compression at all. They were completely cured. The 15% we couldn't cure at that stage who were ambulatory all had improvement in their pain scores. Although the 2007 ESHCAR study had shown that treating the veins and stopping the reflux caused less recurrence, it hadn't shown that there was an advantage in speed of healing. However, this was shown by the EVRA trial, another randomized controlled study, that showed that if you treat patients with venous leg ulcers with endovenous surgery, they also heal faster than those patients treated with compression alone. So these two studies show that endovenous surgery or venous reflux ablation in patients with leg ulcers causes a faster healing and less recurrence in the future. So that's all the research. Let's now try to get it into a more understandable form. So first of all, let's think about the pathophysiology. What actually happens when we get a leg ulcer? And the first thing is, so many doctors and nurses talk about venous hypertension, but venous hypertension doesn't really exist. As in my book, the Understanding Venous Reflux book, if you have normal veins, varicose veins with great venous vein incompetence, or venous leg ulcers in 3 patients all at the same height, because the pressure is related to their height, the density of blood, and gravity, all have exactly the same pressure at the ankle on standing. And so there is no venous hypertension in any of these patients. If you do want to cling on to the principle of venous hypertension at the ankle in these patients, you can think about a dynamic hypertension. Looking at this here, you can see that everybody ends up with a same pressure at the ankle, but it's how you get to that pressure. If your valves are working and you stand up, then what happens is you get a slow refill time, and so it takes you a longer time to get to that HROG, or the maximum pressure you can get at the ankle. Whereas if you have no valves and you reflux, then you get there quicker. So there is no actual hypertension, but the speed to getting to the normal pressure is faster. When you're walking, you can also show that the same effect happens, so you can end up with more time with pressure at the ankle during the normal walking cycle. But again, you don't get any excess pressure, you just get a quicker or longer term increase of pressure, but it's never more than the normal pressure you get for your height. One of the things that I find worrying for doctors is that we seem to understand passive or gravitational reflux quite easily. The valves don't work, we stand up, blood falls down the veins, and this is the reflux that we all know in the great saphenous vein. But doctors find it far harder to understand systolic or active reflux, where the reflux only happens when the muscle contraction occurs. Now, in the small saphenous vein, a lot of people think because it's a long vein, it's passive reflux. But of course, the valves in the deep veins above it are working, and so just standing up would not cause reflux of any great amount. However, compression of the calf muscles causes blood to squirt out through the incompetent vein, causing a wave of pressure to the ankle. And once you understand that, then of course you also understand perforators. Now, many people still argue that incompetent perforators are not relevant. And of course, virtually every randomized controlled study that has looked at venous leg ulcers and whether you close the perforators or not have shown that incompetent perforators are directly related to these changes at the ankle and ulceration. So therefore, when we talk about venous reflux in the superficial system, we have to think both about the active as well as the passive reflux, or as hemodynamic people sometimes call it, and I don't like it, but they call it diastolic and systolic reflux. So in very simple terms, what are the causes of venous leg ulcers? On the first one here, we can see great venous vein reflux. The second, we can see incompetent perforating vein reflux. The third, great venous vein reflux with incompetent perforating vein reflux. The fourth, deep vein reflux with great venous vein reflux and incompetent perforating reflux. And on the fifth, we can see that there is deep reflux only. In these patterns, which ones are curable and which ones are not? This can lead us on to look at obstruction itself, and classically we like to think of the Maytherna in this situation, or Nivel, where an iliac has been blocked and therefore there has to be a bypass either internally or, as on the right hand side here, externally through veins that pass the blood over to the other side to get back to the heart. Although once upon a time this was very difficult to treat and people used to do the Palmer's sort of bypasses or leave the patients in compression forever, nowadays with stenting this is easier and easier to treat by those experts who specialize in the area. The third cause of inflammation at the ankle that causes venous leg ulcers is venous stasis, which is often seen on ultrasound as large dilated veins under the ulcer bed. And this can be caused by venous reflux or obstruction, so it coexists with the others, although it can stay by itself in people with paralysis or who don't move very much, or sit in front of the TV with their legs down, or maybe have a fused joint. So venous stasis can either be present by itself or it can be present as part of the whole venous reflux or obstructive pattern. By understanding this simple diagram of venous stasis, you can see that anything that compresses and empties that venule after the capillaries, whether it be compression, elevation, or physio, or using a neuromuscular stimulator or pump, anything that empties that is going to actually improve the area temporarily. Although, of course, if you use sub-ulcer plexus foam sclerotherapy, you can cure this permanently. So I'm going to run through a couple of cases. The first one was a 69-year-old lady with a 20-year history of varicose veins who presented to us, and a strong family history with a father who had a compression hosiery since 21. This lady had had a 4-year history of venous leg ulcer, and this was stopping her getting a hip replacement as they wouldn't treat her with an open wound. Over those 4 years, these are all the specialists that she had been through to try and get to the bottom of the reason that she had a chronic leg ulcer. This slide represents the cost to the NHS of this patient. When you actually look at all the things that she had during her time, in the 4 years she had her leg ulcer, which still wasn't healed, it had cost more than £25,000 in products alone. Regardless, this doesn't even take into account the nursing salaries and the doctor's salaries. It only accounts for the things we could measure. She also had had her hip replacement postponed for the 4 years, as we said before. Fortunately, she found about our protocol and she referred herself to come and see us. She had a venous duplex ultrasound scan. We treated her with endovenous laser treatment of the great venous vein, as I'll show you in a minute, as well as the perforators, followed by foam sclerotherapy to the stasis veins. We started a bit of compression early on in her recovery and then discharged her with liaison with community nurses. This was her venous duplex ultrasound that showed an 18mm totally incompetent great venous vein with 8 incompetent perforators. And of course, none of this had been looked at previously. All of this had just been hidden away under compression. This is the story in pictures. In October 2016, you can see this big open ulcer when she referred herself. You see by December when she had the endovenous laser ablation. Then she came back looking much healthier in June 2017 for her foam sclerotherapy. 4 weeks later, you can see the March 2017, that's 4 weeks after the foam, but 10 weeks after the EVLA. And by May, you can see that it's almost completely healed. And she went on to have complete healing and went on to have a hip replacement. The cost analysis shows a very clear advantage by doing this, because when we add everything together in the healing time of 18 weeks, the total cost £5,446. And when you compare this, this actually includes consultants' time as well. So there's an even bigger saving than it looks at first glance. She went on to get her hip replaced and went back to a normal life, and now unfortunately is suing her GP and nurses because they refused to change their practice even when we pointed out her care to them and how she had changed. And once they refused to change their care pathway, she decided that the only way doctors and nurses would listen is if you take a legal route. The second case from the same book is a young man who is 34 years old who right the way from school knew he had severe varicose veins, and by 2019 had a venous leg ulcer that was treated traditionally by dressings alone. Because he was so young, they refused to believe this was venous in nature, and he was diagnosed as pyoderma gangrenosum and was put on steroids. Unfortunately, he had terrible problems with steroids, with a fracture of 5 of his vertebrae, and even dislocated his knee before he found out about our work. When he had his duplex scan, he was found to have great venous vein reflux, small venous vein reflux, as well as 4 incompetent perforators. Endovenous ablation of his truncal veins and trollop technique for his perforators followed a few weeks later by foam sclerotherapy, and lo and behold, once again, complete cure, and now absolutely no need for any compression. He regularly goes to the gym, he's running 10 kilometers a day, and unfortunately, once again, because his doctors won't listen, he's ended up having to sue his dermatologist for the unnecessary steroids and chemotherapy, as well as the loss of earnings he had because he wasn't able to work during this time. Ashish came to visit us from the Samata Hospital, and he saw all of our work and took our thoughts home, and we published this case report with him of a lady who had had a resistant and, as you can see, really horrible venous leg ulcer for 5 years. He performed EVLT followed by foam sclerotherapy, as is our protocol, and lo and behold, this lady got a cure, as you can see here, and we published this, as we can see, in the Wounds Asia in 2019. Now, not everybody can get a venous duplex ultrasound at the same levels, and not everybody wants to treat all the perforators or are able to. And so Ronald Bush has brought this idea out called the TIRS, where you only look at the terminal veins or the subalcer plexus, and you use foam sclerotherapy in them. This certainly heals ulcers, but it probably doesn't give such a good long-term result, but without doubt it can be repeated. So the role of compression has completely changed in ulcers. It's not a treatment, and we should never think it is a treatment unless the patient is incurable. We should only use it for patients awaiting investigation and treatment, or in the short term for treatment post-foam sclerotherapy. We should only ever use it in the long term if we're unable to operate, or it's not worth operating on the patient, or after surgery the patient's healed but the limb is still swelling. When compression is needed, of course, we need to make sure we have good quality compression. This new device that's shortly going to come out, called the GraduCheck, will not only show that the graduated compression being put on is adequate, but it will also monitor it during the treatment to make sure it stays at the right level throughout treatment. Of course, we must also remember, though we can fix the veins, there's no point if we can't move the leg, because pumps need both valves and movement. Therefore, we must keep patients walking, use neuromuscular stimulation and external pumps if needed. Dressings are largely irrelevant, and certainly some of the claims made by dressing companies are ridiculous. Many keep the skin macerated in the area, which worsens pain and also helps the skin breakdown and the ulcer to spread. Therefore, I more and more am using scabs to allow the natural wound healing underneath the scab, and find this a very useful way to make sure that the dressing is exactly the right size, and it's of course much less expensive and much more patient accepted once they get over the shock of seeing the scabs. We probably don't pay enough attention to nutrition, and certainly patients with chronic diseases and chronic illnesses, certainly with inflammation, are always low in vitamin C. So all of these patients should have high vitamin C diets, and we also need the high protein diet for the building blocks for the new cells and protein for the subcellular matrix. So in conclusion, venous leg ulcers are not different from varicose veins. It's a progression of venous disease. Most cases are curable surgically, and most only need superficial endovenous surgery with ablation, perforator ablation and foam sclerotherapy. Compression is now secondary to endovenous treatments. Don't waste money on expensive dressings if you haven't fixed the veins first. And in your enthusiasm to get the veins fixed, don't forget that you need mobility and pumping of the ankle, good vitamin C and protein levels. When we cure venous leg ulcers, it's less expensive in the long term than regular dressings and compression, and saving both the health service and patients money, as well as giving better quality of life for patients, as well as their carers and their family. Thank you very much for your attention.